live in 3, 2, 1. Please start, sir. We are live.
Good morning, all distinguished delegates and our eminent speaker, Dr. Jagdish Hiremath, sir. I am Satish Ramajoshilkar from Zydus Medica, honored to welcome you on this scientific platform called CLEARTalk. So on behalf of Zydus Life Sciences, I first of all would like to express my most sincere gratitude for your presence on this scientific webinar. For giving a small brief about CLEARTalk, CLEARTalk is one more facet of Unite Against Dyslipidemia. And the recent development in the field of dyslipidemia management is bempedoic acid and clear outcomes trial, which was presented in ACC 2023 recently. So hence this session of CLEARTalk is focused on this development of clear outcomes trial. So we have one of the best faculty of international faculty, Dr. Jagdish Hiremath, sir, and would like to give a small brief introductory presentation about sir. This is a very small slide. I could able to manage his entire affiliations and rewards and recognitions in one slide. So, Dr. Jagdish Hiremath, sir, is the director, Cath Lab, Ruby Hall Clinic, Pune. He is a cardiologist, heart transplant department of Ruby Hall Clinic, chair professor of preventive cardiology, MUHS. He is a teacher of DNB and DM cardiology, investigator of international trials of NOAC, PHA, and he is a very prolific speaker, more than 3,000 talks to his credit. So we have one of the best faculty of international stature. I would like to hand over this session without wasting much of our time to Dr. Jagdish Hiremath, sir.
Yes, thank you, Dr. Satish and Zydus team. In the next 30 minutes or so, we'll try to cover what bempedoic acid has brought on the table. Because we've been using this molecule maybe for a year. We saw that the levels of LDL are coming down as we desired. But there was no outcome trial. In my own mind, I never had any doubts that there will be outcome because all the outcomes are related to the LDL levels. And anything that reduces the LDL levels is bound to show some outcome or the other, and that's what we find. So we'll try to see the nitty-gritty of the outcome trial of bempedoic acid. Before that, I'll share my screen. Today we meet here as a part of the CLEARTalk. And as I said, recording and lecturing is a way of life for me. So I thought I would show you this photograph as well. If you look at the dyslipidemia management of 2023, we say total cholesterol has lost its value because we hardly do any calculation of risk in India. HDL cholesterol as a good cholesterol has lost its value because all the trials related to increasing the HDL have failed. Triglycerides have a borderline, shall we say, importance because if it is too high, it can cause gallstones and pancreatitis. And if it is higher than 200 in a ischemic heart disease, it may have some implications. So it's still borderline important. So of the four factors of lipid profile, what we are left with is LDL and LDL and LDL. So whatever we do, we need to reduce LDL as of today. What will be the outline after 2 years, 3 years? One really has a clinical curiosity related to that because medicine as a science keeps evolving and keeps changing. And we shall talk of what is good today and what we need to do, follow the science. Very clearly, these are American statistics. If you look at this figure from say 1960 onwards, maybe around 1970, the total cardiovascular burden, disease of the heart, coronary artery disease, stroke, all have been going down. These are fantastic epidemiological surveys. I really don't know how they are done, but it shows that the advent of statin in the 1970s had brought down these levels. It is also said that a young graduate of United States doesn't want to become a angioplasty cardiologist because there is more market related to degenerative diseases and pacemakers and electrophysiology. Jokes apart, we know that this cardiovascular burden is going down with the advent of statin. And all the trials that we have been studying, whether it is multiple trials of statins or fibrates or niacin or PCSK9 like evolocumab or the ezetimibe trial, all of them have shown us that reduce LDL and reap the benefits. Lower is better is the mantra of today, and it is related to the LDL levels. Also, it is important that nowadays direct estimation of LDL is done in the lipid profile, unlike the calculated version which was in the past. Also, what has made a difference is the non-fasting sample of blood for LDL levels. So LDL estimation has become easier, it's become more reliable, and we have now one target to aim at. And that's why lipid management probably has become easier today as compared to what it was 2 years ago. So the logical question is, what is the clinical benefit on attaining the LDL goals? We know that each millimole, which would be about 39 milligrams percent, which comes to improvement of the events reduction according to number of years in the trial. For example, a trial was conducted with follow-up of more than 6 years. Longer is the follow-up, better are the reduction in the risk taking place. So it's the total exposure of the LDL for that individual, and total reduction of the LDL levels for that individual matters a lot. And this also emphasized here in the lower part of the slide, risk of non-fatal myocardial infarction, CHD, death, and stroke over a period of 5 years. More LDL is low, all the values are low. We know that lower is better is what is being emphasized here. And all the trials, starting from the Forest trial of simvastatin, I think this is almost 30 plus years old. Then came the CARE trial, then the high-dose atorvastatin TNT trial. And then the mantra that time was high LDL is bad, average is not good, lower is better where the TMT started. Even lower is better when ezetimibe and other trials came into picture. And when the PCSK9 inhibitors came in, they brought down the LDL levels further, giving more clinical benefits. So lowest is the best is what we believe today. As of now, there is no J-shaped curve. That means even if you lower it very low to 20 and 15, so far at least it hasn't shown any bad effect, as it is seen maybe in hypertension, as it is seen in maybe other areas of medical management. So today we go by the fact that lowest is better, and lower is better for longer is also easier to understand concept. So our single target is LDL, and it is always said that lower is better, and we have to be gender neutral these days. So it's like a modern day jeans. Lower lower you wear it, the better it is, fine fashion wise. So how does LDL lowering matter? It's not just the LDL level, but it also leads to increase in the fibrous cap thickness. The plaque becomes more stable, and regression to some extent takes place, and reduced plaque burden and MACE also takes place. There are many trials or guidelines to quote from, but I want to quote only one, European guideline of 2019, and then I'll quote Indian guideline. It is because 2019 brought in the real focus only to LDL, doing away with the HDL, doing away with the triglyceride and the total cholesterol levels. So the ASC guideline of 2019 said that if somebody has a moderate risk, LDL level should be below 100. Any adult after the age of 40 should be below 116. Higher risk individual below 70, and very high risk individual below 55, and very, very high risk will be below 90. Now, what is very high risk? What is very, very high risk is easy to understand. Anybody who has atherosclerotic cardiovascular disease becomes a very high risk individual. And those with familial hyperlipidemias and severe kidney disease, diabetes and target organ dysfunction, all these subset that we know, mentally also we know that this very high risk group, that is the one which is brought down to 55. And the LAI, Lipid Association of India goal said that in normal individual with low risk, maybe LDL should be 100 in India, Anybody who has ASCVD, atherosclerotic cardiovascular disease, or multiple risk factors like diabetes, hypertension, smoking, and other would be below 55. And anybody which is higher risk than that should be, in fact, below 30. Very dramatic figures these, and we should all be following that in order to bring a change in our patients' outcomes. So the treatment goal of LDL across categories of severe risk is like this. And you can see the low risk, this is European guidelines, moderate risk, high risk, and very high risk. So very, very high risk means somebody who is on statins being treated, but still gets within 2 years another ASCVD event. He should be brought down to below 40 is what European Society tells us. And Lipid Association of India tells us to bring these people below 30. It's a busy slide. It's a extra reading for all of you because I can't take you through this slide, which will take a long time. And anyway, you wouldn't remember all these things. The bottom line is you have to think of a person with low risk, moderate risk, high risk, very, very high risk, and extreme risk. Extreme risk category A is somebody with a coronary artery disease and features of very high risk group, that is diabetes, CKD, and other things, which we garden variety of patients that we see. They have to be below 55, but you can optionally go down to 30. And extreme high risk category B, that is coronary artery disease, and somebody who has suffered an event in the first 2 years would be going down to 30 without any choice. So let me put it very simply. You can read this later on of the Lipid Association of India. Somebody who has atherosclerotic cardiovascular disease, stroke, myocardial infarction, angioplasty, bypass surgery, peripheral arterial disease with multiple risk factors, the target is below 55. And such an individual suffers an event while on treatment has to go down to 30 is what we should remember. And other things, of course, will be in our smartphones to remember. So extreme high risk group A, you have to come down below 50, and choice that sometimes you feel thinking, oh no, this is still very high risk, I'll bring down to 30. But extreme high risk category B, you have no such choice. You have to bring them down to 30. So we know now that the LDL levels are going to be lower and lower. So when it comes to management of dyslipidemia, the statins are the agents, but do all statins user achieve the LDL-C goals as per the guideline recommendation? We know that the answer is no. And how to achieve this LDL-C target after maximally tolerated doses of statin are given? And we know the answer is the non-statin groups like the ezetimibe, the bempedoic acid, when required, the PCSK9 inhibitors. So based on the revised ESC 2019 guidelines, how many patients do control to LD? This was a study called the Da Vinci study. Those who are avid book readers, we know that Da Vinci Code was a book which was exceptionally very hot bestseller some years ago. So this study called Da Vinci study conducted in Europe, in fact, looked at 18 countries in large number of patients, nearly 6,000 patients, who were given for primary and secondary prevention the statin, and they were given according to guidelines, whether statin, high dose, lower dose, or whatever. And what is the startling here is these are the barcodes. Again, I don't want to go into the details of this slide, but it says here that only 27% eligible patients were receiving high-intensity statin. That means 100 were eligible, but only 27 given. It is obviously the physician component, either not giving good dose or the patient not tolerating would be a patient component. And other than that, 30% of the patient achieved lipid goals with high-intensity statin. 100 should have achieved, but only 30 achieved. That means there is a big scope for other agents to pitch in and do this job of LDL reduction very effectively for all our patients. Another startling study related to Da Vinci study was that 37% of the eligible patients were receiving high-intensity statin. We saw that, and 22% receiving LDL goal with high-intensity statin. That means A, they were not given good doses of statin. B, despite giving the doses, they were not achieving LDL levels. So there is scope for additional agents. It's very clearly visible from that. And here is the second concern. Suppose you want to give a 80 milligrams of atorvastatin to somebody long-term, 40 milligrams of rosuvastatin. How to achieve these LDL targets after the maximum tolerated dose of statin is given? Patient don't tolerate, they get cramps or they get other symptoms, and we have to then reduce the doses. So either A, you have achieved the best dose, but LDL levels are not achieved. And B, because patient cannot tolerate, you have achieved maybe half dose of what is desired. Then what to do, how to reduce the LDL levels. And it is very clearly demonstrated that high intensity statin, people don't take it very often. Observational study of 23,000 patients of acute coronary syndrome who were prescribed high intensity statin after the index event. 66% of these patients, I said, did not take high intensity statin after discharge. A large population, which is the educated population, follow-up is good, but they did not take it. More than 50% had drug interruptions at the end of the therapy within the first 1 month after the index event. And non-adherence to high-intensity statin has a strong association with higher mortality by 16%, as it is seen on this side. So somebody deserves high-intensity statin or reduction in LDL level and doesn't take that medication for various reasons. Maybe it cost, maybe it is side effects. It is going to adversely affect that individual. And here is the role or the niche for bempedoic acid, a first-in-class LDL lowering drug. Actually, all of us are now fairly familiar with it. Approval date was 2022 in US, and India is now doesn't lagging behind anymore. It reduces uncontrolled LDL-C with maximum tolerated doses of statin alone in mixed dyslipidemia, familial hyperlipidemia, high risk of ASCVD, where you want to reduce the LDL to a great extent, it will be of use. Statin intolerance, for whom statin is contraindicated because of, say, rhabdomyolysis, then you have to use this agent as a first choice with or without ezetimibe or PCSK9 inhibitor. 180 milligrams per day is one single oral day with or without food. Now, we are familiar with HMG coenzyme pathway for statin. Actually, bempedoic acid is in the same pathway, higher up about 2-3 rungs higher than this pathway. And this is seen, of course, in liver. It is seen in other areas like the macrophages. And more importantly, this does not express itself in the skeletal muscles. So the statin muscle intolerance or muscle side effects do not appear in bempedoic acid in majority of the patient because it doesn't act on the muscle at all. It is, the action is only in the liver, in the same pathway as statins, but a little higher up on the HMG coenzyme A pathway. Since bempedoic acid does not activate in skeletal muscle, as HCl is not expressed in the muscle, the side effect profile is going to be better. So how do we use it? Its a half-life is good, so it's truly once a day. We don't have to worry about elimination factors with renal, fecal, and other things. If there is renal impairment, minor one, up to say 30 ml EGFR, no adjustment needs to be done. Hepatic impairment also moderate, say about 2 times raised of the SGOT, SGPT, you don't have to worry about it. But for these are not green flag, but all patients, we have to monitor and be cautious. All patients with uric acid, when it is somebody suffering from gout, or patients who are more than 60 years of age, taking corticosteroids or other quinolines, renal impairment, history of tendon rupture. Because these two things, like higher uric acid and clinical manifestation as gout and tendon rupture, is something which we have to be wary of. And the people who are prone for that should be monitored. It's not that it's contraindicated. However, there are red flags when the patients are moribund like this and there is a tendon rupture already taken place, you cannot give. And those people who are taking maximum simvastatin dose, fortunately, we don't use simvastatin anymore here. Pregnant ladies is a red flag, and breastfeeding ladies is a red flag. So if you see it's a very smooth molecule, can be used most of the times, except for the obvious red flags that we know. And what does it do? You can see the ASCVD patient, baseline LDL levels are checked, and then it is checked for ACS, stroke, and PAD. And then they are on 50% reduction. Some of them are on full doses of statin. Some of them are highest intensity statin with bempedoic acid, high intensity statin with bempedoic acid and ezetimibe. And these are PCSK9. All of them reduce LDL very well based on how many combinations that we do. But if you see bempedoic acid very clearly in all features, whether it is familial hyperlipidemia, complete statin intolerance, or highest possible dose and not achieving the LDL, everywhere bempedoic acid helps statins in a synergistic way, in a symbiotic way, to reduce the LDL further. And because of its good side effect profile, probably smoothly fits into the combinations with ezetimibe, with PCSK9, or all the three for that matter together. A lot of study was done related to bempedoic acid with the clarity. So these are called clear harmony, clear wisdom, clear serenity, and clear tranquility. These are 4 trials. Some were on statin, some were not on statin, some were on highest dose of statin, some were with ezetimibe. All these 4 trials finally concluded, and all of us were waiting for the outcome results of these trials. But before the outcome, the clear harmony said that bempedoic acid added to maximally tolerated statin therapy did not lead to a higher incidence of overall adverse event than placebo and led to a significantly lower LDL cholesterol. That means it can be added to maximally tolerated statin. Clear wisdom said that in high risk for CV disease receiving maximally tolerated statin, addition of bempedoic acid compared with placebo resulted in a significant lowering of the LDL-C level over a period of 12 weeks. So this was a higher risk patients with maximally tolerated statin. Clear serenity was a group for safe and effective oral therapeutic option for lipid lowering patients who cannot tolerate statin. So rhabdomyolysis, or there are patients who just don't tolerate. For them, it was clearly working very well. And clear tranquility trial said that it may provide an oral therapeutic option complementary to ezetimibe in statin intolerant patients who require additional LDL-C requirement. That means it can be used de novo when statin cannot be used. It can be combined with ezetimibe. It can be combined with statin, ezetimibe, and bempedoic acid can be combined together. So based on this clear kind of trials, what happened later was the background of the bempedoic acid clear statin. Statin intolerance, add bempedoic acid. What happens to CVD? LDL levels are reduced, yes, but does it affect the overall outcome of these individuals or not? And that's why this thing was, the trial was conducted. And this appeared as a clear outcomes trial published in the NEJM very recently. Obviously, it is as also presented in the ACC 2023. And we are fortunate these days, sitting at home on a Sunday morning, we can get these data so easily. And it's now the onus is on us to understand the data and implement it in our day-to-day practice. So what was done in the global cardiovascular outcome trial of bempedoic acid with statin intolerant patient with elevated LDL was, these are the patients who were on primary and secondary prevention for LDL-C where statin was indicated, but these patients were statin intolerant. So in the screening visits and otherwise, they were put on either bempedoic acid or a placebo, which is looking this. So study completion was almost more than 3,000 patients on either side, and follow-up was at least 2 years. The primary endpoint was effect of bempedoic acid versus placebo, and a 4-component MACE, which is CV death, non-fatal MI, non-fatal stroke, or coronary revascularization. Look at the number, a large number of 13,000 patients, phase 3 clinical trial, and a median follow-up of 40 months, which is a large follow-up. So primary and key secondary endpoint, it says that non-fatal MI, non-fatal stroke, coronary revascularization, or cardiovascular death. One side is bempedoic acid, other side is placebo, and hierarchical testing of the key secondary endpoints was also done. and whether it is reducing or not, or including all-cause mortality. So if you see the two groups, that is the placebo group and the bempedoic acid group, whether it is body mass index, whether it is LDL cholesterol, CRP to start with, then GFR, risk category, glycemic status, statin use, all of them are absolutely matching groups, and that's happened because of randomization. And once they are matching and started on to this trial, all the four areas, whether it was primary, what we said, 4-point MACE, the p-value was good with a 0.05. So at 4-point MACE reduced by relative risk reduction was 13%, 3-point MACE 15, fatal and non-fatal MI 23%, and coronary revascularization 19%. Definitely impressive because we are talking of an era of 2023. The effect of the trial regime on the CV end was, as I said, bempedoic acid was given 4-component, 3-component. We just revise it again. We know that it's a good reduction and the trial is phenomenally successful. So now we have an agent in our armory which can be used to reduce LDL without great side effects and bring in a good outcome for our patients. So clear outcomes, if you see the LDL levels, whether it was placebo and bempedoic acid, marked reduction in the LDL levels without any doubt. And the HSCRP level also were remarkably less, whether it was 6 months, 12 months, or end of the trial. These are placebo levels, and the yellow occur bar, negative bar is the reduction in the HSCRP by bempedoic acid. So obviously there is relative reduction and some amount of inflammatory benefit also related to this bempedoic acid. So serious adverse event, if you look at the ratio is the comparison almost equal. Let's look at myalgia, hardly anything, in fact, less in bempedoic acid. Discontinuing doesn't, not relevant here. Then patient with renal impairment, not a great change. Hyperuricemia was clearly more in bempedoic group as compared to placebo group. Gout, manifest gout, was also higher as compared to bempedoic, and the change in baseline level of uric acid after 6 months was higher. So one has to be watchful of the uric acid effect, but otherwise it's a safe drug and it brought out the change also. So the clear outcome study conclusion was that the bempedoic acid becomes the first ACL inhibitor and first oral non-statin to demonstrate statistically significant reduction in MACE4 events in patients with or who are at high risk of CVD with documented statin intolerance and elevated LDL-C levels. So very bold, dominant, or shall we say, stark statement to make at the end of the conclusion. So it is an effective alternative for statin intolerant patient and clear outcomes, well tolerated, it reduces LDL-C and CRP, reduces primary and secondary endpoints, and it's an effective approach because it's a very smooth side effect, practically side effect free medication in our armory now. So actually we are now used to the heart failure 4 pillars. Antihypertensive, there are 4 pillars. Heart failure, there are 4. In diabetics, we have 4 pillars. So even lipid management, we should have a 4 pillars, whether it is statin to start with, then it could be ezetimibe addition, bempedoic acid, and PCSK9. So bempedoic acid actually represents one of the 4 pillars of the modern lipid-lowering agent. By using this polypharmacy, we should aim at reducing the LDL levels to very low as advised by the Lipid Association of India background. How I go about it is, suppose I get a patient who is a young man, say about 40, 45, diabetic, myocardial infarction, and underwent angioplasty, hypertensive, smoker, let's say, big load of risk. So he is a very, very high risk individual. I know that his target is LDL. Right now, his LDL level is 100. So I have to come down from 100 to 30. It's a very big reduction. And for that, just the high intensity statin is not going to help. So definitely I would add ezetimibe, I would add bempedoic acid. If required, I will add evolocumab to it and bring the levels to 30. Then maintaining them at a 30 at a longer period is all clinical skills based on what the polypharmacy use, how the polypharmacy is employed, how the patient is encouraged, how the clinician is convinced himself to bring the LDL levels down. But this is an era where LDL has to be brought down. Statin alone is fantastic drug discovery, but we need support of the bempedoic acid and ezetimibe or combinations to bring the LDL level to our desired level. I think I shall stop here and we'll take some questions if there are any.
Thank you so much, sir, for such a lucid presentation and to the point presentation. There are a few questions online. So initially you mentioned about ESC 2019 guidelines. So one question is that many patients have uncontrolled LDL-C, but they do not have any complication. So should I increase the dose of statin or to add bempedoic acid or ezetimibe?
Suppose let's take an example. Suppose a person is 60 years old and has a LDL level of 160. Doesn't have anything else, no IHD, nothing. This is what the statement is. Then traditional wisdom says that go for highest dose of statin and bring the levels down to below 100. That is our aim should be. First thing is to decide your target. Go to the LAI slide and then find out where our patient is fitting. Suppose he is moderate intensity, moderate individual, then my target is bring him down to below 100. Suppose he is high risk individual to below 70, and otherwise that is how we follow. So if you feel that your highest dose of statin is going to bring the levels down to your desired target, I would do that first. But it is not practically possible. So many of them would complain of something or the other or the cost when it comes to using the 40 milligrams of rosuvastatin or 80 milligrams of atorvastatin for a long period of time. There, I think my addition definitely is one of the two, bempedoic acid or ezetimibe. I would think that somebody who is say pre-diabetic, I would definitely switch to bempedoic acid because it is very sugar friendly, unlike statins. We know that statin long-term use can have some bearing on the sugar level. Bempedoic acid very sugar friendly. Suppose somebody is a pre-diabetic, has a high LDL levels, then I would use a smaller dose of statin and a good dose, normal dose of bempedoic acid, reduce the LDL levels and be kind on the sugar levels. So it's again, science is very clear. How we use it to our patients is the art of medicine. And I'm sure all of you are champions in that.
Very well said, sir. Next question is about LDL cholesterol is below 40 milligram per deciliter. And can it lead to any neurological complication?
No, it is. I said that there is no J-shaped curve here. The trials related to PCSK9 have had the LDL levels as low as 5 milligram percent, as low as 15 milligram percent, and they've shown absolutely no neurological problems at all. As of today, the science says lowest is the best. So if you can achieve it without causing any major side effect, be it. That means suppose a person is extremely high risk to 3 angioplasty, 1 bypass surgery, peripheral arterial disease, diabetes, then such an individual, I would want him to below 30. And to do that, whatever polypharmacy you use is up to you. But be bold, maintain the polypharmacy. By using pharmacy, maintain the LDL below 30, and it will give you clinical benefits.
Thank you, sir. There's next question, which is around LDL cholesterol. I am having a patient who is having diabetes and hypertension. So, what should be my LDL target in these patients?
See, this person is diabetic, hypertensive, and at present no atherosclerotic cardiovascular disease. That means no MI, no stroke, no CT angio not positive, etc. So this individual, right now, I would manage at a LDL of 55. See, in India, we have to think of normal patient 100, high risk individual 55, very high risk 30. So it's easy to remember these three cutoff. So your patient, I would say, is not normal, and he needs LDL which is brought down. So it's best to bring it down to 55. So whatever polypharmacy it takes.
So next question is about statin intolerance. How you define statin intolerance in your day-to-day practice? Patients having statin intolerance.
Where you cannot use statin at whatever dose you feel. Suppose there is, first of all, some drastic reaction like rhabdomyolysis, liver enzymes getting high or developing manifest jaundice. Then, of course, it is statin. You have to stop the drug, and then you call it true statin intolerance or a total statin intolerance. But there are other people who would complain of a muscle cramps, irritantly complaining of muscle symptoms all the time, where you have to take a call whether you want to withdraw the medicine statin or not. So statin intolerance is clearly based on the patient's symptoms A, or values like rhabdomyolysis and hepatic dysfunction. Wherever you have to withdraw the medicine or reduce the dose, it would be terminated as a statin intolerance.
So there's one interesting question. What you will weight more, LDL cholesterol or triglycerides?
Triglyceride is absolutely not important. It is all LDL and LDL and LDL. Primary triglyceridemia, where the patient's triglyceride 500, 600, I've seen up to 1000. It's a different disease altogether. It has no implication on atherosclerosis. It is a disease which causes maybe gallstones, it causes pancreatic stones and recurrent pancreatitis. So treatment for that is separate, like you have to use the fibrates or fish oil or saroglitazole. That's a different treatment altogether. What we are talking today is treatment for atherosclerotic cardiovascular disease. And for that, LDL is important. In the entire talk, I have hardly touched upon triglycerides, which shows the importance of triglycerides vis-a-vis LDL levels.
That's nice to know, sir. And then probably this is the last question. As per a guideline clinical trial data, is there any beneficial effect of bempedoic acid in pre-diabetes or delay new onset of diabetes?
Yeah, I alluded to that. It is a sugar-friendly molecule. Suppose nowadays there are a lot of executive checkups that are done. A young man at 45 who is overweight, his HbA1c is 6.2, where you don't want to start anti-diabetic medication. But his LDL level is 145, and which you feel because of the family history and all want to reduce it below 100. So such an individual, I would go for bempedoic acid first, because A, he has to take it for a long time. B, it will be sugar neutral molecule, and it will definitely be clinically useful for such an individual.
It was indeed a pleasure having you on board, sir. Before we close or conclude, any final remarks, concluding remarks you would like to give?
Yeah, my concluding remark is that things have become very clear now in 2023. We have clear identified LDL goals. Any patient which comes in front of you, look at the LAI slide, fit the patient into which category is fitting. Based on that, assign a target of LDL to that individual. Then do the calculation. Suppose you want to reduce it 50% and go to the target, then you only statin is not enough. Then you have to think of additions, and the additions could be in the form of polypharmacy like bempedoic acid, ezetimibe. I use sometimes even the PCSK9 inhibitor. But come what may, our goal is to go down to that LDL level. And you can do it nowadays because you have such wonderful drugs and they are all available to us. The cost is reasonable. So we should be able to offer good preventive LDL for our patients.
Indeed, it was a pleasure having you on board, talking about clear outcomes trial and clearing all our doubts on bempedoic acid and usage of bempedoic acid in day-to-day practice. Of course, your in-clinic expertise and experience will definitely help all the delegates to treat their patients of dyslipidemia. We are sure that delegates would have definitely got enlightened regarding the usage of bempedoic acid, as you have covered all aspects of bempedoic acid and clear outcomes trial in your session. At this point of time, I would like to give sincere thanks to all our delegates, and would like to extend my thanks from Zydus Life Sciences. Thank you, sir. Thank you so much. And thank you all the delegates for sparing your Sunday with us. And then thank you all for being with us on this Sunday morning. Thank you. Thank you, sir.
Bye-bye.